And here we go. Welcome everybody to The Big Idea. Dr. Jeffrey Hanna here. Today we're going to be talking about obstructive sleep apnea. And this is kind of the theme and the nature of everything that's on this channel. How is it that an issue in the upper part of the neck can have an effect on parts of the body and functions that we don't even think about? So what we're going to do is I'm going to go through a little bit of research that's just come out. I'm going to talk about a few other factors that we need to consider with obstructive sleep apnea, but then I'm going to walk you through how is it that this area can be having an impact on the throat. Let's jump into it. Okay. Altered cervical proprioception and biomechanics in obstructive sleep apnea, a case control study. Firstly, for English, proprioception. It is the nerve signals that are going to the brain that is letting your brain know where and how muscles, joints are functioning the right way. It's got nothing to do with pain. It's important for motor control, motor function. It's important for balance, for equilibrium. And keep this thought in mind as we are going along here. Garbage in, garbage out. So the joints in the upper part of the neck, they have a huge amount of these things which are called proprioceptors, more than anywhere else in the spine that we know of. And they're always sending your brain signals about where and how your head is in open space. So if you've got good quality information going in, okay, brain is able to process that the right way. But if you've got bad information going in, then you're going to have downstream effects because brain is like, oh, what do we do with this? And it's going to make certain compensations. So keep that in mind as we're having a look at this particular little study right here. So the study aimed to compare cervical proprioception and related biomechanical factors among patients with obstructive sleep apnea and asymptomatic control. So what did they do? They said that we're going to divide this essentially into two groups. They had 59 males. They had 30 of them who had no issues whatsoever, so they were the control group. And they had 29, all of whom had been diagnosed with obstructive sleep apnea. They set them up to the different devices, so polysomnography, so that they could get what's called an apnea-hypnea index score, and they could rate the severity of their symptoms. But what they also did was they evaluated cervical proprioception by using a device known as a laser. Now that's me showing my age. If you actually understand that one, that reference there, please leave a thumbs up or something in the comment section. If you have no idea, write that as well, and I'll be sure to explain and send you to the appropriate channels. But yeah, that's definitely me showing my age. Short of it is that you can wear a certain set of glasses like this, and I've got a laser pointer right like that. And I've done videos on this. I'll put a link down in the description, but it's a way that you can measure neck function. That if you were to point the laser straight ahead at a target, and then you say to a person, okay, close your eyes, turn your head in a few different directions, up, down, side to side, and then one at a time, bring it back with your eyes closed to where you feel that center is. The farther that you are off target, even if you're not having neck pain, it means, whoa, there's a mismatch of information. Something here is not working right. This is used assessing people for whiplash, for concussion, a whole bunch of big things like that. So really important way of assessing. They also checked neck range of motion. They did a few x-ray measurements as well, where they were looking at a person's posture to see if there were structural anomalies wrong with the neck. They tested the strength of the muscles by tucking the chin in like this, seeing how well a person could elevate that. And they were also looking for pain registers. In other words, they were looking for lots of different biometrics about how well these people's necks were actually working. What did they find? They found firstly that in the group with obstructive sleep apnea, they had on an average 26 events per hour. And this is the concern with an obstructive sleep apnea. It means that you are literally not breathing. You're breathing and then it stops. Your brain is not getting oxygen. your brain's not getting oxygen, man, that's going to have huge downstream effects in ways that we can't even fathom. It's one of the reasons why obstructive sleep apnea is such a concern for so many people. It's not just a matter of, oh, I'm getting a bit of a bad night's sleep. No. This sets the brain and the rest of the body, all of the systems, including how well you can think, how well your organs work, everything for, greater degrees of pathology. So they found that the people with sleep or obstructive sleep apnea, their brain was not getting oxygen 26 times an hour. And they found that they could rate it there in terms of overall severity. In a nutshell, they found that a third of the people had mild obstructive, a third of the people found they had moderate, and then a third of the people they found severe. Now, here was the really interesting thing. Patients with obstructive sleep apnea demonstrated significantly poorer cervical proprioception compared to the controls with both sides of cervical rotation, with larger effect sizes. They also noticed that there was altered cervical range of motion, that the factors that they were measuring on X-ray and posture, so up at the top of the neck, at the base of the neck, and also the strength of these muscles right through here, every single one of them was altered to the downside for people with obstructive sleep apnea. So what was their conclusion? Impaired cervical proprioception may be a previously unrecognized factor associated with obstructive sleep apnea. Now, I will say that correlation does not equal causation. So is it possible that people with obstructive sleep apnea have neck issues as a consequence? That's one possibility. The other possibility that the authors here are raising is that the problem with the neck is actually contributing toward the obstructive sleep apnea in the first place. We don't know for sure which one it is, but most likely it is a two-way street, one way or another. Fascinating, because this means for a lot of people, yes, you still may need the CPAPs and to be doing all of the other kinds of stuff, but it means one of the things that we might be historically overlooking for helping people so that they are breathing better when they're sleeping, so their brain gets oxygen, is looking at the upper neck. Now, for me to sit here and say that would be the only thing you got to work on, that would be insane. That would be stupid. I'm not going to do that. So I want to hit on some of the other more traditionally recognized things with obstructive sleep apnea first. Then I'm going to get into a few mechanisms that the neck could be having an impact here. So the first one that I want to hit on is the one that people are probably most familiar with. Simply put, it's if a person is overweight. If you're overweight, you've got more tissue mass, both a combination of muscle, but also fat that is literally choking you off in this area right through here. And if that starts to produce inflammation, which is oftentimes associated with being overweight, even if it's not overt obesity, that's going to cause swelling in the back of the throat. All of this works towards closing off the airway like this. As a consequence, there is a physical blockage that is preventing air from getting down into your lungs. What do you have to do in this situation here? It means it's the conversation that a lot of times we know, but we don't want to have. You got to lose weight. And as important as exercise is, the number one factor, as I talk about in a good number of my other videos, it is diet. You've got to work on diet. Here is the rule of thumb. And it's good to have blood tests to find out what things you might be sensitive to. But any food, anything that you eat, drink, inhale, ingest, anything like that, if you feel congested in your sinuses and if you feel bloated right here in the upper part of your abdomen, it's producing inflammation from the inside out. You ate something that is not good for you. And it's promoting inflammation. Inflammation is going to promote weight gain. If you can get whatever that something is through a process of trial and success out of your diet, that will make a huge improvement, not just towards a sleep apnea, but toward anything that's going on in your body. So you can use that little litmus test to direct you to find out what it is. In my opinion, everybody should have a little bit of sin in their life, but it's when that sin, the exception, starts to become the new rule. That's where we're running into trouble. So that's number one. Number two, it is your head position when you sleep. So for a lot of people, what they do when they sleep, if you're on your side, we have the tendency to stick the head forward like this and we roll up in a little ball in the fetal position. Or if we are a back sleeper, what we do is we use a pillow the way that we think we're supposed to. We're going to stick it under the base of our head. Now, here's the kicker with that, is your shoulders, your torso is going to weigh more than your head. So what's going to happen is your shoulders are going to sink into the mat, and then your head is going to start to protrude forward like this, even if you've got a very thin pillow. Now, try this as a little exercise. What I want you to do first, sit up nice, tall, and straight. And I want you to position your ear so that it's basically over the tip of your shoulder like this. Not leaning your head back, but just sort of upright military posture. And take a deep breath in. And let it out. Now, I want you to stick your head forward on purpose as far as you can. And try to do the same thing. You're going to find that you have to work a lot harder to get air into your lungs. When you stick the head forward like this, that is going to choke off your airway. And the position that we sleep has a major effect on that. So if you are a side sleeper, what do I advise? It would be that you take your pillow and shove it back. Oftentimes we're going to put the pillow so that our shoulder is in the middle part, but that leaves this big platform on the side so that we can stick our head forward like this. If you slide it back, your brain knows that there's a cliff edge right there. It's going to keep your head more aligned over the tip of your shoulders. That'll help to keep your airway open. That's number one. Now, if you are a back sleeper, I need to show you how to use a pillow the right way. Take the pillow and slide it down so it's cradled under the base of your shoulders. That way, it's going to keep everything in relative alignment like this. And this, again, can be a big problem for a lot of people. If they've got obstructive sleep apnea and they've been given a CPAP machine, they find, okay, in order for me to wear this thing, it's hanging on my face, so I have to sleep on my back, but I also have to be slightly upright. In and of itself, it's not ideal, but the problem is that they still put the pillow under the base of the head, and it still sticks the head forward like this. So whether you are perfectly flat or even at a slight incline, make sure if you're sleeping on your back that the base of the pillow goes under the base of your shoulders here. That way it's going to make sure that as the device is supplying you with extra oxygen, it actually is going to have a place to go. So sleeping position, that is number two. Number three, this is going to be jaw position. And this is something where you might have to work with your dentist, specifically what's known as a neuromuscular dentist. The short of it is that if you have what's known as class 2 malocclusion, aka an overbite, that also is going to choke off your airway. Try this as an example. Again, bring your teeth kind of together on purpose, and I want you to imagine that you are giving yourself the biggest overbite that you are able to. So stick in the bottom jaw back, try to take a deep breath in. Then, on purpose, glide your bottom jaw forward as far as you can, kind of like you're a bulldog, so like that. And take a deep breath in there. I think that what you're going to find that the farther that you can bring the jaw forward, the more functional space makes for your airway. Again, it makes for things easier to actually flow. So an overbite is not simply a matter of aesthetics. It actually has a function on your overall airway. Dentists have known this for a long period of time, and there are a number of dentists who work specifically with correcting alignment of the teeth, again, not solely for aesthetics, but to keep the airway open so your brain is getting oxygen. Super important. So don't rule that out as another factor. The fourth one that I'm going to hit on is a tongue tie. Tongue ties exceptionally common, and our tongue is supposed to be completely mobile in our mouth. If, however, we have a tongue tie, even if it is not affecting our speech, this is a risk factor that has the tendency to cause the tongue to roll farther back in the mouth when we are trying to sleep, and the tongue itself then can start to become the obstruction, which is affecting the airway right here. This can oftentimes be addressed with what's known as myofunctional therapy. Think of it to a certain degree as physical therapy, but for your tongue, because the stronger you can have that and moving and functioning actually the right way, the better it helps the airway. It sometimes may also require, if it's pronounced enough, a tongue tie release, where again, they use one of those little devices called a laser. They make a small incision like that, and that frees your tongue so that it can actually start to function the way that it is supposed to. Ideally, we see these things when kids are itsy bitsy little, because this can also have an impact on latching. So the ability for a newborn to be able to properly suckle, get nourishment, but also speaking. But this can also go undiagnosed all the way till we are adults. One way or another, it's never too late to work on these different kinds of things that can affect our health. So those are just 4 of those other factors there that I don't want to dismiss as they relate to obstructive sleep apnea. Number 1 being overweight. Number 2, your head sleeping position. Number 3 is going to be the alignment of your jaw. And number 4 is going to be the function of your tongue. But let's go back, because again, what these researchers are saying is they're saying, again, not necessarily a causative, but they're saying that there's an association and something going weird in the neck. This could actually be affecting how we are able to get air into our lungs and contribute toward the obstructive sleep apnea. So I'm going to walk you through a little bit about how that might be possible. Let's have a look. Ta-da! It's simple. What is this horrible picture here? This is a schematic of what's known as your craniocervical plexus. It is the major nerves that come off of the base of the brainstem up here inside of the skull, and that are going to descend downward and can be influenced mechanically by what's going on in your neck. It's also schematic for all of the different nerve branches that come out of the C1, the C2, the C3, and the C4 levels of the upper part of your neck. I am not going to torture you with all of these details right here, but there's going to be a few branches that I want to highlight for you that can be influenced by this guy right here, the top vertebra in your neck. Firstly, just to help orient you a little bit more, there is this opening right here. So this one is going to be the base of the skull. It's what's known as the foramen magnum. But there is also this guy right here. This is what's known as the jugular foramen. The jugular foramen is a feature. It's deep inside of the skull. It would almost be like if you took your finger from behind the corner of your jaw and could go straight up. It's located right about there. Don't do that. Don't poke yourself there, because that opening is going to contain a number of different vessels. It's going to contain the internal jugular vein, which is bringing blood back down from your brain, but it's also going to contain 3 nerve branches three cranial nerves. In reverse order, it's going to be the spinal accessory nerve, so that controls your traps and also your SEM, so major head movements. It's also going to contain the vagus nerve, which is the guy that is going to be responsible for sending all of the information from your brain to your heart, lungs, digestive system, and back. And it's also going to contain in the orange what's known as your glossopharyngeal nerve. This guy's got a number of branches that go to different parts of the inner ear that's involved with blood pressure, but it's also going to go to the back of the throat. So let me show you these just a little bit individually. Okay, firstly, glossopharyngeal nerve. I'm not going to hit on every single one of these, but I am going to hit on 9.2 and 9.3. So the nerve has come out through the opening of the jugular foramen. 9.2 is going to be a branch that goes to what's known as your stylopharyngeus muscle. It's a muscle that goes from the back right here and actually attaches onto the back of basically the muscles of the jaw, the back of the throat. In other words, if you've ever got irritation, constriction of this particular muscle, it can start to affect how we swallow, how we talk, but also the airway. And you've also got this little guy here, which is 9.3. This is going to be a series of nerve branches that go directly to those muscles on the back of the throat. It forms what's known as the pharyngeal plexus, because again, it's not just one nerve. It is going to be the sensory branch for all of what's going on in the back of the throat. Follow that up with vagus nerve. Vagus, baby, vagus. what we've got illustrated for you right here. We've got 10.3. You can see that it says it goes to 9.3. Why? Because this is the motor supply for almost all, with that one exception. This is the guy that controls all of the muscles about how you are actually swallowing. So if you've ever gone to your doctor, neurologist, something like that, and they say, okay, what we want you to do is open your mouth and say, what we're doing is we're looking at the back of the throat to see if the arches are rising symmetrically. If you see things are normal. If you see things are not rising on the one side, that means that there is a weakness of those particular muscles. And if you've got weakness of one, guess what? You probably have weakness of the full lot. So you've got two nerves right in the top of the neck that are going to be having an influence in terms of how these airway muscles are actually able to function. Now, the question then is, well, how is it your neck can actually influence nerves that are coming out of the base of the skull? Well, do you remember where I said where that jugular foramen was located? What I've got is a giant model of C1 right here. Jugular foramen would be located right here. So if we were looking top down, it would be just above this spot right here. This is the front, this is the back. So I've got it upside down, but you'll get the idea. In other words, these nerves and these blood vessels are going to transmit down along the front of the neck right here. And we see this on diagnostic imaging all of the time. That if, because we've either projected our head forward like this, or we have had some kind of physical injury that has made it so that that vertebra is not functioning the way that it's supposed to. It can start to glide and it can start to lock in an abnormal position forward. Only about 79% of the time. You get the idea that it happens in a huge amount of people. Now, if you've got these blood vessels that are located right here and also these nerves, your jaw is going to sit right here. So as this starts to come forward, it starts to create a narrow space between the back of the jaw and what's known as a styloid process, the attachment for a few muscles and for a few ligaments. In other words, that starts to make that space smaller. If that space becomes smaller, this can start to be like a source of mechanical irritation, not unlike a pebble in your shoe. If it's ever very, very severe, it can cause craniofacial pain, it can cause fainting spells, it can cause disequilibrium, what's known as a craniocervical, or depending on the cause, it can also be known as an Eagles syndrome. I've done a few videos about those. Point being is that the mechanical issue with the upper part of the neck can influence the glossopharyngeal nerve and also the vagus nerve, the two very important ones that are involved with, again, blood pressure regulation, with the function of your vital life organs. Remember, garbage in, garbage out, but it can also influence the branches that are going to control how tight these muscles are going to get in the first place. So keep in mind, first and foremost, that mechanical source of potential irritation if and where that C1 vertebra ever misaligns forward. Does it have an influence on the back of the throat? You bet it does. And mercifully, this is going to be the last schematic that I'm going to show you. What we're now looking at are all of the various branches from the C1, so top bone in the neck, C2, C3, and C4. I don't going to go through all of these individuals, so don't worry about that. But simply put, you'll see this big little loopity thing that we have right here that's formed between the C1 and between the C2. Every single one of these little branches here go to what are called strap muscles. Strap muscles are the ones that are going to be located deep on the inside toward the front of the throat. This is what allows you to be able to move your tongue. This is what allows you to be able to swallow. This is what allows you to be able to speak like this. And you can imagine that, and again, don't do this, but if you were putting your fingers on these muscles right through here, you can see, and I'm not trying to put it on or anything like that, when I deliberately make those muscles tighter, what it does is it affects the way that I can talk, it affects the way that I can swallow, it affects the way that I can breathe. So remember what we had said here earliest from the very, very beginning, garbage in, garbage out, and proprioception. If the brain is ever not getting proper information. It's getting garbage information because the sensors in the neck are determining there's an injury here. Something's not right. Even if it's not broken, even if it's not bleeding, even if it's not bruised on the outside, and even if your x-rays or your CTs and your MRIs say that there's no pathology here, it doesn't mean that there is not a functional disrelationship that is sending your brain abnormal proprioceptive information. Now, if your brain is not getting a clear map about what's going on, it's going to have to produce certain compensations. And one of the ways that it does this is, in order to get more appropriate feedback, is it causes muscles to tighten as you go down the kinetic chain. So if there is a problem on the upper part of the neck here, it's going to cause all of the motor branches there potentially to start to tighten just a little bit. And what did we say? If you start to have tightness of those different muscles that are going to be going, that control how you talk, how you breathe, that can start to have an impact in terms of our airway. And again, we see this all of the time when we are looking at a person's digital images. When we're first doing an assessment, we can see that there is constriction. We can see that there is narrowness of the airway. And again, it's not always a dental and it's not always an overweight side of the equation. And in fact, there are a few upper cervical chiropractic specialists who are doing some pre and post research specifically looking at the airway pre and post adjusting this guy in the upper part of the neck. In other words, the evidence that we're currently accumulating, we still need to get a whole bunch more. It's in support of what these researchers have found, that again, the upper part of the neck can have an influence. Again, not the sole cause, but neurologically. Can and does it have an impact on our airway and can contribute toward obstructive sleep apnea? Yes, it can. So that's what I've got here for you. I hope you've enjoyed this video. If you have, please always do make sure that you're clicking that like, subscribe button. That way it helps other people find this particular video. And if you've got that friend, that family member, that client, that colleague, they're dealing with something like this, they've had the sleep studies, they're trying to do the very best that they can, but this area has not been properly addressed. Maybe they're having balance issues. Maybe they're having headaches. Maybe they're having migraines. Maybe they're having something else, even something as quote unquote benign as, yeah, my neck always feels stiff and sore. Well, if you've got obstructive sleep apnea and you're also saying, yeah, my neck feels a little bit stiff and sore, there could be this kind of connection. Please share this video with them. If you want more information about the kind of work that we do, how we can help people out, you can go over to our clinic website, which is clearchirospokane.com. You can also check out a number of the other videos that I have on this particular channel, and I do hope that you find good use, good value in them. Thank you guys again for watching this. Till next time, this is Dr. Jeff at Clear Chiropractic. Get well, live well, stay well.